welcome everyone signing in. That's just gone on the hour, so we can go ahead and get started. So hello everyone, and welcome to this webinar from the Immunization Economics Community of Practice on the economics of adult vaccination. So we've got four fantastic speakers with us today, and without further ado, I'll go for a few housekeeping pointers. Next slide, please. So at the bottom of the screen, we have a chat function. Feel free to introduce yourself and to chat with participants and panelists using this chat box. We also have a Q&A box where you can submit questions to the speakers at any time during the presentations and the webinar, and we'll come to them at a Q&A session at the end. And just to let you know, this webinar will be recorded. Next slide, please. Great, so we can get started. So let me introduce myself. My name is Christina Banks. I'm a technical advisor at Thinkwell and part of the team managing the Immunisation Economics Community of Practice. For those of us joining us for the first time, our Community of Practice is a platform on immunisationeconomics.org through which we promote and encourage the generation of economic evidence to support immunisation programmes in low and middle income countries. So if you're not a member yet, please head to our website and sign up for our newsletter. So to briefly explain how this adult vaccination webinar came about, around a year ago, we ran a survey where we asked our members what topics they would most be interested in, which informed a series of webinars, of which this is one. And the economics of adult vaccination came out as a key priority to our members. And then when we take a look at the economic evidence for immunisation programs historically, it makes sense that this was raised as a priority because globally there's more and more attention for the benefits of adult vaccination. But when we look at the economic evidence base, most of this has traditionally focused on childhood immunisation programs, which one of our speakers will show us later in further detail. So with this webinar, we aim to fill that gap and answer the key questions that come up regularly, like is it more expensive to reach adults with vaccines than it is to reach children? And how do adult vaccination programs vary? And how does that affect what delivery strategies and incentives programs might be efficient at reaching adults? And so to discuss some of these questions, we've invited key researchers that have worked on adult vaccination economics over the last year. So we can take a look at our agenda. First of all, we'll have Alba Vilajulu, who will speak to the global status of adult immunisation, followed by Flavia Moy, who will present findings on the cost of reaching adults with COVID-19 vaccines in 7 countries. We will then have Ranju Baral presenting on the cost of maternal immunisation delivery, and Nina Schwalbe on vaccine incentives and whether they work. Next slide, please. We can move on to our first presenter. So Dr. Alba Vilajulu currently serves as the technical officer in the Department of Immunizations, Vaccines and Biologicals at the WHO headquarters. Alba, over to you.
Thank you so much, Christina. It's a pleasure to be here today. So in the coming minutes, I'm just going to present, and if we can go to the next slide, a quick brief on where we are on global status of adult immunization. Next slide, please. So why extending the benefits of immunization to the entire lifespan? So when 50 years ago, because in 1974, when the EPI programs, so the expanded programs on immunizations were established, the world was a different place in terms of the distribution of the population by age groups. So I know it's a bit small in this slide, but what you can see in the graph, it's the 2 lines, the one that it's orange and the one that it's green. One represents the green one, represents the under 5s. And then the orange one represents those that are 60 years of age or older. So where we are right now, 50 years later, it's that in 2025, there are more people that are 65 years or older than children younger than 5. That's a big change. And by 2030, almost 1 billion people will be, it's expected that almost 1 billion people will be over 60 years of age. So the world changing, we also have to adapt our immunization programs. And in the Immunization Agenda 2030 vision established that vision where a world where everyone, everywhere, at every age, fully benefits from vaccines for good health and well-being. And when I say at every age, that means that from pregnancy to newborns to infants to childhood, adolescents, and then as well as healthy adults, which includes healthcare workers, as well as those with chronic conditions or immunocompromising conditions, as well as older adults. If we go to the next slide, we can see that there are benefits that could be at the three levels. The first one is at individual level. We can expanding or unlocking the full potential of vaccines through the life course. We're able to extend the life expectancy by preventing deaths, also the life quality by preventing disabilities, and also allowing the elderly to be more active and productive longer. In terms of the society, we could see that we could promote economic prosperity through touch points for catch-up to increase population protection. It could be also for diseases that might be emerging, like measles. It could be also a way to fight against antimicrobial resistance. And I'm not going to go in detail because other speakers will speak about that today in terms of a cost-effective and cost-saving intervention. In terms of the health system, we also see it as a way to promote sustainability by reducing the burden on the healthcare and the cost save, and also, most importantly, to providing infrastructure to deliver other primary healthcare services with the idea to move towards a people-centered approach. Next. And if I'm able to leverage the data of the analysis, a paper that we just published on the latest data that has been reported to WHO and UNICEF through the EGRF by countries. So this is the data reported in 2024. Countries are now reporting the data in 2025. So it means that the latest that is available is the 2023 data. So when we look at the national immunization schedules and to the question to which vaccines are included there, for older adults, we know, and that's reflected also in the map on the right side of the slide, that we know that by then in 2023, and please take that with a caveat that was reflected in that moment in time, for COVID vaccine, more than 90% of the countries across all income groups reported having COVID vaccination vaccine for older adults. This is the first graph on the left side. For seasonal influenza, that was the second vaccine that was mostly reported as part of the national immunization schedules, 59%. However, we see a big difference between 89% reporting in high-income countries versus 8% in low-income countries. The next vaccine was pneumococcal vaccine. 17% of the country reported that. However, again, most of them high-income countries, 40%. And then herpes zoster was only reported in high-income countries and only represented 7%. So we certainly see that there are big disparities in adult immunization policies across the globe. And I just use the group of older adults, but we also see that with other groups, that it could be those with chronic conditions as well as pregnant women. Next. I want to also highlight that these are the vaccines that we know are already, I mean, the previous slide is the vaccines already as part of the national immunization schedules already available, but we also know what's in the pipeline. And when we look what has been recently licensed, as it is the case of chikungunya or respiratory syncytial virus vaccines for pregnant women, and also look at what is in the phase 3, like next generation of tuberculosis vaccines, phase 2, Group B streptococcal vaccines for pregnant women, or phase 1, as it is the case of HIV vaccine, then what we see is that in bold, those that are going to be targeting adults or adolescents, meaning that there is a need to really have a platform where to be able to provide those vaccines. Next. So as a takeaway, what I want to say that looking ahead, we really need to look at and think about how we routinize adult immunization programs, because over the last 50 years, EPI has become one of the greatest public health achievements in history. However, to date, adult immunization efforts, mostly in LMICs and LICs, have been limited to routine vaccination of pregnant women as part of ANC and mass vaccination efforts as part of that response of public health emergencies as COVID. Now, however, with an intense focus on the role of prevention of chronic diseases and healthy aging, and a rapidly expanding pipeline of adult vaccines, as I just showed, there is an unprecedented opportunity to build the success on the existing vaccines as well as build for the future. So there is an urgent need to break down the artificial divide between the efforts to encourage the healthy aging styles, so the package of interventions, routine adult immunization, with the idea that maybe 50 years from now, we'll be able to look back and see that how the routine adult immunization programs became a central pillar in adding productive and healthy years to the societies at all income levels. So thank you so much.
Great. Thank you so much, Alba, for that introduction to the topic and the overview of the current global status. I'll move on to our next speaker. Flavia Moy is a senior technical advisor at ThinkWell.
Thanks,
Flavia, over to
Christina.
you.
Thank you. Next slide, please. So today I'm going to be talking about findings from a multi-country study on the cost of delivering COVID-19 vaccines. Next slide, please. We'll start by looking at the evidence on delivery costs for adult vaccination, then briefly introduce our study and COVID-19 programs in the countries we analyzed, to then move on to results and takeaways. Next, please. So what do we know about the cost of vaccinating adults? Next slide. So to answer this question, we looked at the immunization delivery cost catalog, which is an annotated database on the cost of delivering vaccines in low and middle income countries. This database includes all delivery cost evidence published between 2005 up until about a year ago. So the immunization delivery cost catalog shows that most of the delivery cost evidence available is for childhood vaccination programs and for preteens. Next slide. So delivery costs for vaccinating adults make up about 23% of the evidence base in the catalog, or 159 unit costs. Most of these unit costs are for reaching adults and children, or adults and adolescents, while about 7% of the evidence is for delivering vaccines to adults only target population. Next slide. So if we zoom in into this evidence, we see that most of the existing data on adult vaccination is for routine delivery, while 35% is for supplementary immunization activities, and the remaining 11% is for cost estimates that combine both routine and SIAs. Next slide, please. So if we break down the evidence further to see what antigens the unit costs available are for, we see that the great majority, over 70%, are for COVID-19 vaccine delivery. If we look specifically at routine delivery, we see that almost all of the evidence is for COVID-19, which is you can see as the dark green on the donut chart. And all the unit costs that combine routine and SIA delivery are also for COVID-19, and also a large share of the evidence on supplementary immunization activities is for COVID-19 vaccination campaigns. There is evidence for cholera campaigns, yellow fever, meningitis, and influenza campaigns, but all these campaigns target both adults and children. So we know that more evidence is emerging now on maternal immunization, and we'll hear about that in the next presentation, but there is still no evidence for other adult immunization programs. Next slide, please. So given that COVID-19 studies make up most of the evidence on adult target populations, it is essential to contextualize the cost evidence on COVID-19 vaccine delivery to understand what learnings can be extrapolated to other adult vaccination programs. Next slide, please. So let's spend a few words about our studies before going into the results and takeaways. Next, please. Okay. So we conducted an ingredients-based bottom-up costing study of COVID-19 vaccine introductions in 7 countries, namely Côte d'Ivoire, the Democratic Republic of the Congo, Uganda, Mozambique in Africa, and Bangladesh, Vietnam, and the Philippines in Asia. We collected data at 290 sites and estimated economic and financial costs from a payer perspective. When possible, we also disaggregated findings by delivery strategy or by implementation period. And we also conducted a qualitative assessment to complement cost findings. Next slide, please. So during the study period, all countries deliver COVID-19 vaccines on an ongoing basis, what we're calling in this slide a continuous delivery modality. And in addition to that, some of them also implemented some kind of campaign-style supplementary immunization activity, though there were significant difference in terms of what this actually looked like in countries. So while all countries use a mix of delivery strategies, some of them deliver mostly, for example, at temporary sites that were maybe active every working day for months and months on end, as was the case in Mozambique during the study period, while other countries mostly delivered at health facility with some regular outreach, as was the case in Bangladesh, and other countries yet used a mix of both. Next slide, please. So this graph shows the percentage of each country's population that received at least one dose of COVID-19 vaccine between February 2021 and December 2022, while the labels on the right show the cumulative number of doses delivered in million. As you can see here, both the volume delivered and the speed at which countries managed to vaccinate their population varied significantly among the countries that we looked at. While most countries were able to successfully reach their target populations quite quickly, you can see that the program in DRC didn't really pick up during the study period. And I should also add that data collection in each country took place at different moments. So the cost estimates that I'm going to show next represent different periods of 2021 or early 2022. Next slide, please. Next. So let's dive into the result. So this graph shows the financial cost per dose of delivering COVID-19 vaccines in 2022 US dollars for the 7 countries in our study. So in general, we can see the financial cost per dose was low. The 2 countries that stand out for higher costs are the DRC, where the program faced significant vaccine hesitancy and never really achieved high delivery volumes, and the Philippines, which was the only country that was able to mass hire additional health staff. In other countries, the low financial cost was really the reflection of high delivery volume, but also very limited additional investment. So across the board, we observed the use of cost-cutting strategies like virtual training, but we also heard a lot about severe staff shortages and delays in disbursement that led to insufficient fundings, particularly at implementation level and particularly for vaccine distribution and storage. In several countries, we also heard about health staff having to fill funding gap using their own resources, for example, paying for fuel or using their own vehicles. And incentive for health workers and per diem were deemed absolutely insufficient by health staff, and they were reported to be the cause for low morale in more than one country. Next slide, please. So this graph shows the economic cost per dose, also in 2022 US dollars. And I should say that economic costs are the sum of financial costs, which are monetary outlays, and opportunity costs, which represent the value of using existing resources. As you can see, the economic costs were much higher due to high opportunity costs of labor. This is because the very limited additional financial investment resulted into unsustainable practices, such as having health staff work overtime, and on weekends for months and months on end, and also resulting into the mobilization of into the mass mobilization of volunteers. Our qualitative assessment also found a very high level of political prioritization to reach vaccination targets and contain the pandemic as quickly as possible. So this means that some of the key elements that made COVID-19 vaccination programs successful and possible at this low financial costs are unlikely to be found again outside the context of a pandemic. Next slide, please. So this graph shows the economic cost per dose across implementation periods in Vietnam, Uganda, and Mozambique, as well as the target population for each period, and the average doses delivered by sites per day during each period, which you can see in brackets below the period level. You can see here that reaching priority adult target population in the initial rollout period was costlier. And when eligibility was expanded to all adults or adults and adolescents, the cost per dose delivered went down. However, initial rollouts were also characterized by severe, thanks, Christina, by severe constraints in vaccine supply, which caused inefficiencies and higher costs. And some countries also reported challenges and inefficiencies related to identifying and ever-changing target populations during the initial period. For this reason, the higher cost that we see in the initial rollouts when priority populations were targeted are more likely to be due to the intrinsic characteristics of these periods and the low volume delivered rather than to challenges of reaching these priority populations. Next slide, please. So here we're looking at the economic cost per dose for different strategies in the DRC, the Philippines, and Bangladesh, as well as the target population for each strategy. You can see here that after the initial rollout, so when the programs were delivering at scale, the costs still varied widely depending on the delivery strategy that was used, even when the target population did not change. We can also see that in Bangladesh, the one delivery strategy that was targeting only children was the least costly of all, but it was also the one that achieved the highest daily delivery volumes with almost 1,000 doses delivered per day on average. Next slide, please. In fact, if we put together all unit costs for all delivery periods and strategies, we can see that volume delivered rather than the target populations explains the variation in costs. Next slide, please. This is even more evident if we look at the relationship between the doses delivered at sites, which are shown in this graph on the x-axis, and the cost per dose delivered, which is on the y-axis. So you can see here that there is a clear inverse relationship, meaning that the cost per dose was lower at sites that delivered more doses. And this holds true across target populations, countries, delivery periods, and delivery strategies. Next slide, please. If we compare this cost to those for childhood routine immunization programs, we see that at high enough delivery volumes, the financial cost per dose was similar to that for childhood immunization programs, which is shown here with the darker line. If you can move on to slides, please. So what can we learn from this? Most COVID-19 programs were very effective at reaching adults at a low financial cost per dose, thanks to the exceptional commitment of health workers and the very high volume delivered. As we saw, volume was a key determinant of the cost per dose, and at high enough delivery volumes, costs were similar to those for childhood vaccine routine vaccination. However, when targeting small adult populations, delivery volumes are not likely to be sufficiently high. Therefore, integration through existing platforms will be essential to achieve efficiencies and contain costs. Thank you. Next slide. Thank you. That's it for my presentation. And if you want to learn more about our studies, you can find country reports on immunizationeconomics.org.
Great, thank you, Flavia. So we can move on to our next speaker, and I'll just give a quick reminder. You can introduce yourself in the chat, submit questions in the Q&A at any time. We welcome any questions for the speakers. Our next speaker, Dr. Ranju Paral, is a senior health economist at PAF. Over to you, Ranju.
Thank you, Christina, and it's a great pleasure to be here. So thanks also to the organizing committee. It's a great platform. So what I'll be talking today is around the cost of cross-country study where we looked at the cost of vaccinating the pregnant women. And I'll go briefly over the study process, the methods and the approaches that we took, and highlight some of the key findings. Next slide, please. So this is the work that we did in very close collaboration with the ministries of health across the study countries and many partners like KEMRI in Kenya and BPKHS in Dhahran. And this work was funded by the Gates Foundation. So just wanted to acknowledge all the collaborations. Next slide, please. So here's a quick agenda that I already spoke about. Next slide, please. Um, yes. So first, why this study? So when countries consider introducing new vaccines, the immunization program cost and the affordability are the key questions, and it can be a significant cost that is borne by the countries, and also a potential barrier for the equitable access of these new vaccines. And as we saw previously, and the previous speaker also spoke about the solid evidence around the childhood immunization cost that already exist across the low and middle income countries. However, the data are very limited on what vaccinating pregnant populations cost like, especially in the low and middle income countries. And the delivery strategy and the cost might differ for MI, the maternal immunizations, from that around the childhood vaccines. So there's quite a big gap around, the knowledge, what we know about vaccinating pregnant women. So to help fill in this gap, we conducted this perspective with the cost projections across 5 countries, namely Bangladesh, Ghana, Kenya, Mozambique, and Nepal, and in collaboration with the local partners. And the main objective of this study was to understand the cost of delivery and the introduction implications of these new vaccines that are given in pregnancy, and to help enhance the understanding of the economic feasibility of implementing these upcoming maternal new vaccines. Next slide, please. So on the methods, very quickly on the methods. So this was the prospective costing study, or in other words, the cost projections of the anticipated, delivery strategy for the upcoming maternal vaccines. The maternal vaccines that are, there are many maternal vaccines in the pipeline, and those vaccines were not available at the time or even now that are widely used, that are not being currently used in the low and middle income country settings. So we had to do the cost projections. Unlike in the previous study, I think that was the retrospective where we're looking at the actual expenditure. Here we're doing the projections of the cost. And we took the government's perspective, although, usually at the time of the new vaccine introduction, there is usually some donor or these other support, like, for example, from the Gavi that might be available to the countries to help support the introductions. Given we did not know about the financing mechanism around those futuristic vaccines, we assumed that we just went ahead in estimating the total cost from the government's perspective, acknowledging just the fact that the financing might be different when those products are available. We looked at the incremental cost, meaning the additional cost to the existing programs in creating that platform for the MI intervention delivery. It was an ingredient-based activity costing, where basically we identified all the different activities that might be associated with the new vaccine introduction and delivery, and were costed individually. And the activities were, included various standard activities like planning, coordination, communications, training, vaccine procurement and delivery, etc., which are pretty standard. We generated both the financial and economic cost, and as was also shown by the previous speaker, the financial cost include the direct financial outlays or the expenditures that is required for the introduction and delivery, whereas the economic cost, in addition to the financial cost, incorporates also the opportunity cost of the existing resources and the donated goods. And so basically the main difference there is in this particular study is that we assumed the vaccine product would be donated to the government. So those were only included in the economic cost. And another major chunk of the economic cost constitutes the cost of the existing labor that would be required for all the different activities associated with the maternal immunization program. Next slide, please. So very quickly in the study process, here, as I said, these new maternal vaccines, uh, like for example, the RSV, the GBS vaccine that are in the pipeline were not yet available in the countries, nor were they in the use in the countries that are study countries. So and introducing these new vaccines through the existing health systems, there's a good understanding that that might require some adaptations with the immunization programs who primarily lead the immunization programs across the countries, and the maternal health service program where the pregnant woman's touch point is primary, the primary touch point to the health system is usually the ANC programs. So we needed to first understand what those delivery strategies would look like, what the platform would look like, what the strategies might look like in each of these countries, so that we are then able to generate more robust cost estimates. So it was really important to understand the program perspectives from the countries. Therefore, we started with convening in each of these study countries, the stakeholders convening, and informed by which we then proceeded with the cost projections of the prospective costing study. And then because these cost projections are usually based on a lot of some assumptions and inputs from the countries, we then took those stock of activities, inputs, and assumptions to do the validation with the respective countries and the related stakeholders as well. So just to complete the process. Next slide, please. Just a glimpse of what the stakeholder workshop looked like. So the main purpose there, again, as I said, was to discuss the feasible delivery strategies for successfully implementing the future maternal immunization programs within these respective health systems in each of these countries. And we brought together somewhere between 30 and 60 participants in each of these countries, which included the national, subnational level Ministry of Health representatives, including the NITAG members, the program policy managers, the academic research institutes, the NGO sector involved in both the maternal health as well as in the immunization program, to have that vibrant discussions around, what those delivery strategies might look like for these upcoming new maternal vaccines that informed and that formed the basis for the costing study. Next slide, please. Quickly on the data collection. So once we, understood with the guidance from the stakeholders around this delivery strategy, we then identified the focal points within the immunization program as well as the MNCH program leads, work with the, at the national, mostly at the national level, as well as at different subnational levels in each of these countries, to then map out the different activities around, all the different thematic areas that goes into planning and programming and constituting an effective immunization program. So we developed that detailed activity mapping, and then mapped out the the resource requirement for each of those activities. These activities included any specific sort of system-wide changes and adaptations that were identified by each countries that were necessary to create a conducive platform for future MI interventions. So just to highlight that, that means that the activities that were costed in each of these countries could vary depending on the need that was perceived in each of these countries. And also, we built on the recent experiences of new vaccine introduction and program expectations to inform the resources and as well as the specific activities therein. In addition, we also did the primary data collection from some, up to 10 to 15 health facilities in each of these countries, as well as some additional vaccine stores at different levels, to mostly understand the cost around delivery, how the program functions, to get an understanding around that, and to inform the recurring cost of service delivery. To that informed both not only the introduction but also the recurrent cost. Next slide, please. So here again, just trying to distinguish between the what is included within the financial cost and the economic cost. As I already mentioned, the financial cost included all the direct outlays that were necessary, whereas the opportunity cost and the financial cost combinedly constitutes the economic cost. And here's just a list of some activities that were incorporated, for the costing. Next slide, please. Um, is just some, highlighting some of the key data inputs that went into the costing analysis. The product, and well, we still do not know the cost of what the cost of the future maternal vaccine, and the focus therein was around the RSV maternal vaccine, given that that was in the well ahead in the, in the pipeline. So the product price for the LMIs is still unknown. So we made some assumptions around the cost of the product. We did some sensitivity with different product prices, although that does, you know, yeah, and then you can see that, there is quite a bit of variation around how much the countries might pay around the procurement add-on costs like shipping, handling, etc. The vaccination coverage, there's quite a bit of variation, yeah, on the anticipated vaccine coverage that were used across the different countries. And those, again, came from the countries based on their anticipated coverage, expectations for providing the maternal vaccine during a specific age window across the different countries. And of course, the population is quite different. The size of the total target population is varies by the total, size of the country. And you can see the differences. Next slide, please. So here's my main slide with the results. So there are, as you can see, there are two sets of results for each country, and each country is represented by the bar with different colors. On the left, a block is the cost of delivery, and which includes, which rather excludes the cost of vaccines and other immunization commodities. So that is exclusive of the commodity cost. On the right side of the, the bars, it presents the cost per dose, which is inclusive of the commodity and the vaccine cost. And the assumed, it assumes the vaccine cost of $3 per dose as a baseline. In each of these, the darker shade, the bottom portion represent the financial cost, that is the direct financial expenses, whereas the lighter shade on the top of each bar represents the opportunity cost, and jointly they constitute the economic cost. And as you can see here, there's quite a bit of variation across the countries in the cost estimates that were generated, which ranged the cost of the non-vaccine cost of delivery ranged from $1.30 in Kenya, roughly around $1.30 in Kenya, to $3.40 in Ghana. And for the economic cost, it ranged from somewhere between $2.20 to $4.12 for the non-vaccine economic cost. And of course, once you include the cost of the vaccine, the cost per dose of, implementing this maternal vaccine goes up. Now, while it is difficult or even not advisable to compare the cross countries, the variation reflects the country's capacity and gaps, the resource needs, and the adaptation needed that were identified by the programs at the time of analysis. So that variation is explained by, partly by the status of the countries in terms of, the resource needs. And also just to note that of the, I only presented results for the three countries because the other two are currently under review. Here, now just looking at, how these costs look, when you compare with the other vaccines, there's not a good comparison, but nonetheless, if you're looking at the malaria vaccine cost of delivery in Kenya and Ghana, represented by the red dots. For Ghana, the numbers look pretty close, whereas in case of Kenya, the cost of maternal immunization estimates are slightly much lower than what we found in the malaria vaccine. Also, sharing with the white dots or the gray dots as you are the modeled routine immunization cost of delivery estimates, which shows that the maternal vaccine delivery costs are slightly higher than one would observe for the childhood immunization cost. Next slide, please. Um, don't need to go into the details, but what I wanted to share in this particular slide is the cost drivers. And as you can see, the cost drivers vary quite a bit across the countries. But one thing, that is consistently higher, higher comes up as a major cost driver is the training across all the countries. And it's an important, driver because the size of the training participants that were anticipated for this maternal vaccine were quite large, especially by the need to incorporate the maternal vaccine delivery staffs as well as the immunization program. So that was consistently a major driver. And the other important driver, again, it varies by countries, but the demand creation, the vaccine distribution, and in some cases, like in Bangladesh, the program planning, etc., were some of the major drivers. So next slide. So just to summarize, I don't think we need to reiterate the numbers, but there's cost estimates. I think, the lack of the cost estimates, especially around the adult vaccination and in particular the maternal vaccines was pretty stark. And now, we are starting to fill in that gap. And what the takeaway is that the cost of delivering the maternal vaccines might be slightly higher than the immunization, the childhood immunization. But again, the methodology and everything is quite different in the sense that we are doing the cost projections for the optimal programs. So I think once the new maternal vaccine starts getting rolled out in these countries, it would be good to do the validation with the retrospective cost analysis in some countries up and implementation to to make sure that we can extrapolate this beyond these study countries in a robust way. So that brings to the end of my presentation. So thank you, and back to you, Christina.
Great, thank you so much, Ranju. So we'll move on to our final speaker, Dr. Nina Schwabe, the CEO and founder of Spark Street Advisors, a global public health think tank. Over to you, Nina.
Great. Thanks so much, Christina. Great to follow these excellent speakers. And you can move to the next slide. I want to thank my co-authors. This paper has been published, and I'll share the link in the chat afterwards. Next slide, please. So this study came about when I was running the US government's vaccine COVID response for LMICs in middle-income countries, the donation program set up under the Biden administration. And we learned about all these crazy incentives that were being offered. I mean, first, for any of you that lived in New York, the first incentive was donuts. Krispy Kreme offered free donuts to people that came. We started to read about in Amsterdam, they were offering herring. Cows in India. So there was a whole range of incentives, and we wanted to look at the evidence behind some of these. And in the US, lottery tickets became a big talking point. Next slide, please. So we set out to look at the question of what is the evidence informing these types of programs, and to what extent are these programs effective? And as other people on the panel have talked about, and this is focused on adult vaccines, there's a lot of stuff around childhood vaccines, but the incentives around childhood vaccines are different because you're bringing your kid, and this is about bringing yourself. So we focused on adult vaccines, looking at a range of the literature that existed. Next slide, please. We identified 26 relevant papers on a range, and I think the takeaway from this slide is they're from a range of different types of vaccines, mostly COVID, a range of different target groups, and a range of different types of incentives. And we only identified 4 papers from LMICs. It was a narrative review, but we basically followed a systematic review format. So it's quite a bit of apples to oranges within this. Next slide, please. So to cut to the chase, what did we find? We found that financial incentives had some impact to increase coverage. but only by a little. And we also found within that there was, and I really encourage you to read the paper because it's got a lot of detail in it. We found it really varied. So sometimes it was on first dose versus second or third. Sometimes the impact was higher if it covered transport versus if it didn't cover transport. There was no study on cost or cost effectiveness, zero. So we don't know how much it costs to provide these incentives. And if in fact, we have no sense of cost effectiveness around these programs or impact on long-term healthcare seeking behavior. But there were some, and I'm going to get into some of the ones that were more successful a little bit later. Those are the ones from the LMICs. In terms of the non-cash expense incentives, which ranged from time off, gifts, perks, raffles, drinks, lottery tickets, there was really no evidence of positive effects. Some lottery programs seem to have a little bit of effect, but again, it's unclear what the cost was of providing those programs, long-term effect, second dose effect, et cetera, or the effect on how people relate to vaccines overall. Another thing that we found in our review was it seemed where people were looking at, there was no kind of assumption about what was the rationale for the incentive, what were you trying to get to, what was your theory of change, and where they looked at it. And some of them were, if we offered you an incentive, would you do it? Versus we did offer you an incentive and you did or didn't do it. But in those studies where we looked at, if you offered an incentive, would they do it? A lot of what we found was that we were addressing, or people were addressing what they call the movable middle. So it wasn't really affecting the hesitance, the no intention to get vaccinating. It was affecting, or it was a slight incentive to people who were on the fence in the middle. Next slide, please. The next three slides basically show a same point, which in looking at many of the people on this chat, you're familiar with. Next slide, please. If it comes up, perfect. So there were 4 programs that we looked at, which were in LMICs. And what was interesting about these programs were that they were not specific to the vaccine. They were around health-seeking behavior more broadly. With the exception of one, which was a reimbursement for transport, the others were around health-seeking behavior more broadly. And there's a lot of evidence in global public health and in public health that that's true. So this finding wasn't particularly surprising. So this program in India was around tetanus vaccination and completing a visit. What was interesting also with the tetanus vaccine programs is that it's a bit of, we didn't look at childhood vaccines in part because the reason why people are motivated to get their children vaccinated, it's a stronger motivation often than self. And that has also been demonstrated in literature. People will do almost anything to get their kids vaccinated. So maternal tetanus is a funny one because most women are getting vaccinated in order to protect their newborn. But let's just take this as an adult vaccination. Next slide, please. I think we missed the Mexico one somehow. But there was a similar one in Mexico, but the Mexican study was around completing a certain number of schedules. So it wasn't just about the vaccine. The cash was dependent on preventive health checks, of which vaccination was part of it. If we can go to the second, the Nigeria slide, please. Similarly, in this program in Nigeria, which was a pilot program, but very successful, the cash transfers were around 4 milestones, ANC, visits, et cetera. So not specifically around vaccine, but the cash incentive was around incentivizing a larger pool of interventions completed. Next slide, please. So in summary, in general from these, with a few small exceptions, cash incentives, non-cash incentives were not effective. So although there was no study around the marijuana distribution or around the cows, we can assume from the other programs that were non-financial incentives that these were not effective. Cash incentives takeaway is that they can be effective, but it depends. So incremental amounts didn't affect willingness to vaccinate. If you pay more, and in some studies we found that if you paid too much, it actually increased hesitancy. Um, so that again gets to motivation, and are you hitting the so-called movable middle, or are you hitting the hesitance? Same on the second point. And another point was that the first dose didn't necessarily lead to impact, even if an incentive was offered on the second or third dose, and where it was most effective, where it was linked to broader health-seeking behavior and not specifically around the vaccine. What I think we found almost most surprising in this was it really wasn't about hesitancy. There was no discussion about we're trying to get hesitants to come. So it was unclear really who these programs were trying to target. Next and last slide, please. So from my takeaway in thinking about this, I think the bottom line is there's no simple fix to hesitancy, and cash isn't going to do it. Well, we know a lot about what gets people vaccinated. We know that trust is the critical factor, that it's trust between provider and client, that we need to provide clarity around safety and efficacy, be honest about side effects. But there's no substitution for trust. And as researchers move forward on studying these programs, I think it's important to help unpack the theories of change and what these programs are actually trying to do in terms of changing behaviors. The other thing that's really missing is what happens next time? Do we have to pay those same people, the people that went? Are we setting up an expectation around payment? So what are the longer term impacts of these types of programs? Thanks, that's it. And we can go to questions.
Great, thank you so much, Nina. So yeah, we can move straight to our Q&A. I'd like to thank everyone who's been sending in questions so far. So we can kick off the Q&A with a question for Flavia on the COVID-19 presentation. Were there any co-delivery or integration of COVID-19 vaccine delivery planning with another vaccine or other interventions that we saw?
Thank you. So in short, no, we didn't see any integration, but I would like just to remind everyone that we looked at the introductory period mostly of 2021 and mid 2022, when the effort was really about just vaccinating everyone as quickly as possible and not really looking at efficiencies necessarily, but indeed moving forward for other adult vaccination programs, finding opportunities for integration would be essential to bring costs down.
Great, thank you. And for Ranju, so despite around over 90% ANC1 coverage, it's a question to why we still only have 60% TT vaccination coverage among pregnant women.
So those coverage numbers that were in there were the anticipated coverage based on the performance of the program, in each countries that the countries said that they would anticipate. In some countries, it was based off of the ANC4 coverage, and given the RSV, vaccine was the key, was the primary maternal vaccines that we were considering. It has a specific window in which the vaccine is advised to be delivered between 24. Of course, that window is different across in different countries, but typically around 24 to 36 week is the ideal gestation window. So you have to find pregnant women during that particular gestation window to for the effective vaccination. So the countries said TD2 plus vaccination. In some countries the estimates or the data were very very strong, although the comparison between the TT2 can be given, TT vaccination can be given to pregnant women at any time period during the pregnancy, whereas the RSV vaccine or for some other future vaccines might be a different time period. So it was based on the characteristics that were of the vaccine that would be delivered at that point in time. So it was based on the anticipated coverage from the countries.
Okay, great, thank you. A question for Alaba. So you showed an elaborate pipeline for adult vaccines in your presentation. Given that LMICs will likely have to manage severe resource constraints over the coming years, where do you think that countries' primary focus should be? Like, for example, prioritizing PCV over COVID-19 programs or introducing the herpes zoster virus vaccine?
Thank you so much. That's a great question and really timely in the current environment. So we believe that it's really about prioritization, right? And for the country to define as part of their national immunization strategy, what's the vaccines that are in the pipeline or might become available in the coming years, what's the current situation in terms of their national immunization schedule, what's their approach in terms of moving from childhood vaccination, particularly for LMICs, towards a life course immunization approach. And based on that, consider also which vaccines might be able just to be supported through donor funding, as well as any additional operational support, and also make a plan and see, particularly what we're seeing today in the presentations, aiming to assess what's the economic, what are the cost components, and based on that to make informed decisions. So it's going to be really based on the context of the country where these decisions will need to be made based on NITEC recommendations. It's not an easy answer.
Yeah, thank you very much for sharing your thoughts on that. On Nina, you spoke just briefly at the end about kind of the long-term thinking on incentives. So, can you speak to any sustainability concerns of the financial incentives for adult vaccination that were raised in your review?
Thanks for the question. I think it's less about sustainability and more about sort of motivation and motivating people through a top up or through money versus motivating people. Vaccines are a lifelong intervention, both for you, for your family, for yourself, for your kids. So this idea that you have to pay somebody to do something that's ultimately good for them, first of all, it didn't work. And second of all, even if it did work, that sets up an expectation for next time. And I think in some of the COVID-19, in one of the COVID-19 vaccine studies, they found that people were waiting for their second dose. People knew that there were cash top-ups for the first dose, and so they didn't get their second dose because they were waiting for the deal. And also, we really don't know about the cost effective. We have no idea how much it costs to do a lottery program across a state. I think when you're thinking about sustainability, you have to think about the things that other colleagues have talked about in the total cost of the programs, direct and opportunity costs. I just worry that we're not getting at the right thing, which is people should want vaccines, they should want to be vaccinated.
Yeah, absolutely. Thanks for your response on that. And a question for Ranju. So, do you anticipate that child and maternal immunization could possibly be administered in the same visit? How would that improve the efficiency of service delivery?
I think that would be the ideal case to sort of, limit, as much as we can limit the number of touch points that the pregnant women, the children need to do to the health facility. That would definitely improve the efficiency. But as I spoke earlier about the timing in the pregnancy, if the vaccine demands to be delivered in a certain gestation window, it is less like it is more challenging to overlap those the timing of the vaccination. But yes, I think the ideal would be to sort of overlap it with the existing touch points, and that's why the ANC fourth visit was one of the sort of for the RSV maternal vaccine in particular was the good timing because of the overlap of that ANC visits. So leveraging that would definitely, definitely improve the efficiency of the program overall.
Great, thanks. And then a quick question for Flavia. Has the size of countries, for example, DRC is very large, been taken into consideration for the costing?
So the we took into consideration the size of the country, partly in the sampling. We sampled more sites in larger countries, but the problem in DRC was that they achieved both low coverage and also low volume at each site. So that is partly already taken into account by the unit cost calculation. So we didn't compare total costs, which would significantly vary with the size of each country, but we compared costs per dose, which does take into account the size of the country.
Great, wonderful. We're at time, so unfortunately we need to conclude the Q&A. But for anyone whose question didn't get answered, we'll compile written responses and post on our website. A final thank you to everyone who's joined, and we'll be sharing the materials and recording from this webinar. And again, if you're not already signed up, then please sign up for our newsletter and follow us on social media to find out all the latest news and research. Have a great rest of your day.
Thank you. Thanks. Bye-bye.
Thank you.
Thank you.